Hello everyone, welcome back. This is Health Economics, Chapter 4. So today we are going to go over the socioeconomic disparity in health. So in Chapter 4, there are quite a few theory and hypotheses that we want to go through in order to talk about disparities among different populations, like people in different age, people with different education backgrounds, or people with different income level, or any other thing that could contribute to the socioeconomic disparities in health. So in the previous chapter, we pick up this one very useful model. It's what we call the Grossman Model. So in this model, we actually find out that individuals actually choose the level of health they want according to the time constraint, the budget constraint, and also what's to do to maximize their utility in life. So the optimal amount of health actually changes based on the decisions about trade-offs between all this constraint in time, incomes, and also other things in life. But how does socioeconomic status affect people's choices on health? Does health actually determine the socioeconomic status, or does the socioeconomic status determine someone's health? So we are going to use some empirical evidence to explore this question in this chapter. So in the first sections, we are going to kind of study the topics on health disparities and what do we observe from the reality. So let's first begin with the word health disparities. So health disparity actually coming from the fact that there are differences in health, such as the incidence, prevalence, mortalities, and the burdens of disease between specific populations. So for example, we might actually find the death rate for all cancer types for both men and women are highest amongst African Americans in the United States. So this actually brings up a concern because, well, what makes African Americans to have a higher death rate if they get a cancer comparing to other ethnicity groups like Asians, whites, Pacific Islanders, or maybe Hispanics? Well, there should be some reasoning for that. So we are trying to see if we can answer the problem of health disparities. Well, this problem actually is ambiguous in the worldwide border. So it's actually found not only in the United States, even though with the diversity ethnicity in the United States, it not only happens here, because disparity actually found with people in a different group of populations, such as people between peoples in different education attainments, people who have a different employment grades, or maybe people in different levels of incomes. So it's not necessary to be only related to races or maybe ethnicity. So it broadly across all socioeconomic status, not only just one. Let's take a look at some of the evidence we found, and this evidence is actually described in the book. If we are going to take a look of the disparity amongst education, different education attainment group, college graduates in the United States are 25% more likely to survive to age of 68 than students who actually graduate from high school, or maybe a high school dropout in this case. So that means people who have a lower education attainment, like the people who drop out from high school, actually is 25% less likely to survive to age of 68. So they might actually have a shorter life comparing to people who have a higher educations. Also, in the United States, we found that white populations usually report a better health comparing to Hispanic and Black populations. And at the same time, Hispanics usually, again, report better health status comparing to Black individuals. This health status actually deteriorates with age across all races, but then these disparities between different ethnic groups still persist. Also, in the book, there is a table suggesting the evidence of income can also be contribute to health disparities. So as you can see, there is a self-reports surveys that illustrating the better self-report health actually tend to be the healthier populations. Well, not only just that, the same surveys were done 10 years later, and the individual who reported poor health in 1984 actually seems a drop in household wealth, while those who reported excellent health in 1984 actually seeing their wealth nearly double. So obviously, this self-report status actually it's a powerful predictor of future health. So it's another evidence suggesting maybe a better health person actually can make more money in the future. So in most cases, the incidence of disease actually found much more in the poor population than the rich, which is somehow an indicator of poor usually got into more of this health problem comparing to the rich populations. Except for some cases where there are sometimes we don't find the differences, and in some cases we might find it counterintuitive that, for example, the hay fever was actually more commonly diagnosed amongst the rich populations comparing to the poor. Well, is it evidence suggesting that the rich actually got into a bigger problems to get this hay fever comparing to the poor? Well, it may not necessary, because to be honest, one very logical explanation to this problem is there might be just because the rich people or the rich households, they have a higher income so that they can actually send their kids or children to visit doctor more often, so that it can be easily diagnosed with those hay fever at the earliest stage. Comparing to the poor, maybe they will just sit at home and try to take some of the medicine themselves and not to see the doctor, so that they won't be diagnosed with those disease. So in this case, it might not be necessarily true that the rich people actually has more high fever or higher chance to have hay fever comparing to the poor. So all the evidence that we found will actually happen in the US. So is there anything that different if we are going to look at other country outside the US? Well, let's take a look at some of the countries out there with a different healthcare system. Let's look at Canada for saying. Canada has a universal health insurance, so that means the governments actually pay majority of the healthcare, or they cover most of the healthcare costs in the country. Well, in this case, people don't need to actually pay much of a out-of-pocket payments like the people living in the US. So income might not be a problem here. However, there are still very strong evidence suggesting a health disparity between different social-economic groups. So infants that born into poor family in Canada are actually nearly twice as likely to have poor self-reported health comparing to those born to rich family. And not only just that they have this huge difference of poor health reported by the family parents, but after the age of 10, the gap actually widens a lot. There are other evidence was suggesting England also got into the same situations where they found a very strong evidence between different social economic backgrounds, populations, which we are going to discuss in later. So in general, we can actually summarize there are several majority of disparities that we have found, such as education, wealth, race, and social standing. So all of these are factors that contribute to health disparities in our study. So in the next section, we are going to discuss what explains the health disparities in the country. There are many reasons that explain the health disparities nowadays. However, in this chapter, we would like to focus on mainly 6 reasonings so that we can put it into different theories to explain why health disparities actually exist in today's date. Number 1, it might be because of early health events. So something happens in our very early life that will actually play an effect causing the health outcomes in the future. Your income levels, so higher income level, lower income level, obviously affecting the resources devoted on health productions. Stress of being poor. So stress definitely is one of the reasons why people actually don't feel they are healthy. Sometimes it could be mentally, it could be sometimes mental could cause a problem physically too. Work capacity. So your work also will affect how you think about your health or how you actually spending resources on health. Impatience sometimes also explain how people actually putting more time investing for their future health. If they are more patient comparing to people who are impatient, that might have less of a time and resources to devote on future health. And also adherence to medical advices. So some people actually might be taking the medical advice more efficiently comparing to other people. Depends on the understanding of this medical advice or maybe how likely they will follow those advice in the case of sickness. Well, in general, understanding these reasons, it's the beginning because policy will design to adjust for these health disparities actually needs to focus on the true problems. So we have to actually find this one solution to attack the roots of this problem. So what causes what in general? To be honest, we have found some evidence that suggesting maybe people in different health status, they might actually have a higher level of socioeconomic status or lower socioeconomic status. And we have also other evidence suggesting, well, because those people in the higher ranking of the socioeconomic status that causing they have a better health later, or maybe there are some other variable in betweens that we haven't defined yet. So in general, we are going to use some of the most popular theories to try to explain what is driving the health disparities in the society. So remember this MEC curve, the marginal efficiency of health capital curve. This curve actually indicates the returns on each additional units of health capital devoted on our lifespan health utility. In this graph, actually, we believe different socioeconomic status group might actually have a different MEC curve. So some of those socioeconomic group might have a higher efficiency to devote resources on health. There might be some groups that has a lower returns. So this is being explained if it is true that different socioeconomic status group has a different marginal efficiency of health capitals, then we can actually try to use this hypothesis here, which is what we call the efficient producer hypothesis, to explain why there is a health disparities between different education attainment group. In this hypothesis, we actually assume that better educated individuals are more efficient producers of health comparing to less well-educated individuals. By the Grossman model, we can actually predict people with a more efficient health productions. That means the person can actually use less of the resources in life to produce more health. Usually those are the people who will choose to have a higher health. There are some evidence suggesting this theory is correct or supporting for this hypothesis here. The ones that is being found in Loris Monet in 2005, she actually finds evidence that an additional year of schooling actually caused as much as 1.7 year increase in life expectancy for those who born in the year of 1925. So this is a very strong evidence suggesting people with higher educations, they will live longer. So what are some of the possible reasonings to explain the correlation between health and educations? So some of the possible mechanisms to explain the correlation between health and educations includes maybe the lessons we learned in school. So there are some health educations that we pick up from high school and colleges that help us understanding how to prevent some diseases in life. Right? So to have a better protections in our life. Maybe this is one of the reasons why higher education is causing a better health in individual lives. Another explanations to it maybe because the school helps students to become a more patient individuals. So it helped them understanding the importance of investments. So not only the investment in income, but also the investment in health. So for example, it could be the case that education help us understanding to exercise 3 times a week. It actually give us a better life in the future. It might not directly contribute to our today's health, but then with better investment into our future, obviously that individual will build a better, healthier life in his lifespan. Well, another way to think about the correlation between health and education may be just basically because a better educated individual, they are more likely to inherit to a very complex treatments regimens. Right? So there are some of the treatments out there that has a relatively complex procedures to follow. There are actually some evidence suggests in the book that patients with a higher education background, they are more likely to keep track with which drugs they are supposed to take and what is the appropriate dose and when they will need to take them. So this treatment regimens actually needs to be followed in some very serious disease like the HIV. So in most cases, the better educated individual who follows this very complex treatment regimens obviously will be able to have a better health comparing to those who actually forgetting to take the drugs and also forgetting to or not be able to understand the complex procedures. Another hypothesis that help explains the health disparities is the thrifty phenotypes hypothesis. This is a genetical reasons to explain why some people are more inefficient at producing health and why some other groups are more efficient. So in this hypothesis, we actually explains in some situations in the early childhood, we might actually encounter into this deprivations of resources. So we might actually have less food to eat, or maybe has less nutrition to consume in our early childhood life, because maybe we are in a poor family, or maybe the mother who carried the baby, she just doesn't have enough income to give the nutritions appropriate for the children's. But anyway, this situation actually causing activations of this what we call the thrifty genes. So this genes is actually very useful in the case of sparse environmental conditions. So this genes actually helps people to survive during those times where food is scarce. But this genes also has another problem to adults. When people start growing up and developing these genes, sometimes when they get into a later life, they might actually getting out of the situations where food is scarce, resources is scarce. They might actually can eat normally like regular people. Well, with this thrifty genes, well, it's actually very bad for adults to actually get into conditions of all this food and resources, its abundance, because we will be eating normally, or maybe sometime eating more than what we need to consume, and it store this unnecessary energies or fats into our body. And this is one of the major causes that we believe later develop into diabetes, obesity, and other disorder later in life. So the disparities actually arise because of poor individuals, right, in their early childhoods. Because in those deprivations of resources conditions, when people don't have enough to feed their children in their early life, or maybe they are just don't have enough nutrition to consume as a mother carrying the baby, it will definitely activating these thrifty genes in the children's body. So to suggest evidence to this hypothesis, obviously the most ideal way is to have this natural experiment to test the hypothesis. So it could be ideal to say, well, we just randomly join some mother and trying to ask those mother not to feed the children's, or maybe not to consume enough nutritions when they are carrying the baby. Of course, this is totally unethical, so obviously no one have done it. So we have to depend other forms of natural experiments. So in the case of collecting the data to support this hypothesis, we have to actually find some natural shocks in the nature. So what are some of the shocks that could happen, such as maybe earthquakes that causing some people might be lacking of these resources during the early childhoods, or maybe snowstorms or something that could naturally happens into our environments. So a good natural experiment actually eliminates this selection bias, so that we can actually have a better sense of how people are behaving, or maybe how body was adjusting with the conditions. So one of the study that it's being suggested in the book that supports the hypothesis, it's the natural experiment during the World War II, is the Dutch feminists. So during the World War II, Hollands would actually suffer feminists due to the Germany blocking the food supplies to the country. So during that time, two groups of people actually created in Holland. So one group that it's in the uteros during the feminists, and the other group is actually being conceived after the feminists. So these two groups are very similar in terms of the backgrounds, except there are some people actually were still in the uteros during the deprivations. And of course, the experiment here is trying to avoid selection biases. So sharing the same backgrounds, suggesting people will behave pretty much the same ways later in their life. So there are some evidence that it's being found by Grossman's study in 2001. And the findings suggesting the babies in uteros during the feminines had a higher rate of diabetes and also obesity in the adulthoods. So that means the behavior of those groups of babies are basically the same. We assume, right, because there's no selection bias. It's not saying that one group of people who are in the uteros during the feminines, they will eat more. But in the case of this, we assume both groups of people actually eating the same level of food, they have the same living styles, they have the same patterns of life, and one group of people actually has a higher rate of diabetes and also obesity. And that's suggesting the activations of the 50 genes in the people or the babies in the utero during the feminines. Well, another hypothesis that we are going to use to explain the health disparities is what we call the direct income hypothesis. And this hypothesis actually assumes that disparities actually exist because rich people basically have more resources to devote on health-related activities or maybe health inputs. Again, we go back to the previous chapter in the Grossman model. We have studied the production possibility frontier model for health. Well, obviously, the rich individual has much more expanded PPF comparing to the ones who have lower income, because, well, this individual can actually devote more and more resources, such as money, their income, or maybe even just time. They can actually have enough money to give up time at work and to devote it on health-related activities. So in this case, the people or the rich individuals may have actually more resources to devote on the productions of both home goods, Z, and also health, H. And that's reasons why the healthier people actually choose a much higher level of health comparing to the ones who earn a lower level of income. So there is another hypothesis also helping us to explain different health outcome amongst different social economic status group. We call this a allostatic load hypothesis. So basically, this is the hypothesis trying to emphasize stress in life as a main mechanism linking this with correlation between socioeconomic status and health. So a allostatic load, basically, it's defined as the repeated stress that creates a accumulative psychological burdens in life, which is true for some people out there. If they're living in a very long-term stressful environment, obviously it's not only affecting the mental issue of the person, but also at the same time has been proven the stress that created in life also linked to many of the health issue we face. In this hypothesis, we actually assume stress is basically one of the factors that speed up the aging process of humans. So the aging actually it's one of the main factors that determines how much health an individual would like to choose in his lifespan. So we actually represents the aging process here as the depreciation rates of health capitals. So the higher the stress it is, it speed up the rate of depreciation, so that the cost for putting more health capitals into our life will become higher. I think most of you guys would agree. Well, if buying, let's say, certain amounts of pills, or maybe getting certain amounts of treatments and paying certain price for it, which help relieving the stress level. But then, on the other hand, we have to give up so much in our life. Sometimes people might choose not to deal with those stress instead of spending the resources like time and income on other things. That's what explained in the Grossman models. So in this case, the higher the depreciation rate of health capital caused by this stress problem in life, obviously, it will affect how people choose the level of health they would like to receive. So one of the evidence that we found in the world actually was suggested by the Whitehall studies done by Mahmoud in year 1978 and 1991. The study actually compares the health status of the British civil servants between the 2 years. This British civil servants are actually a particularly interesting group for the study because first of all, they actually share a very similar background usually, and working environments for these people are relatively similar. Also, one of the most important thing is all the British civil servants actually have the same access to healthcare through the National Health Services. So that means most of the time they have this equal access to healthcare with the same cost that they have to pay, or maybe even none. Given the homogeneity here for both for all the public servants in British, they actually divided up the civil servants into different grades. And there are some very clear evidence that's suggesting the health disparity between the high-graded and low-graded employees. For example, the finding actually suggests disease mobilities and the mortality rates are highest for the lower grade civil servants. And obviously, people who serve in this lower grade civil servants service, they have a higher stress in their work comparing to the higher grade, because the fact that they are being, first of all, offered higher wages, and also usually sent to the work that has lower skilled requirements. The lower grade servants actually report more stressful works and home environments comparing to the higher grade servants, which is a link that we can observe between stress and health outcome. This is also one of the evidence suggesting the lower grade civil servants suffer with a higher allostatic load than the higher grade colleagues, which is causing this stress correlated health conditions. Another conclusion from this Whitehall studies actually suggesting equalizing the access to care does not eliminate the health disparities. So even though people with the same equal access to these health services, but the health outcomes are different. And this also can be explained by the stressful work, or maybe the stressful conditions in life between different grades level of public servants in British. So there is another study also suggesting some evidence to illustrate the allostatic load hypothesis. So in 1990, Smith actually explicitly comparing between the British civil servants and the baboon troops. The result found that the people with a lower ranking of jobs with higher stress actually result in a much lower health outcomes. And this is the evidence actually illustrating being on the low end of the social hierarchy actually produces higher allostatic load, which is the stress. And also this has an adverse impact on psychological outcomes. Well, something that we have covered in related to income. Well, also there is another hypothesis, not only just related to income, but also related to income inequality. So in the income inequality hypothesis, we actually suggesting health disparities are actually caused by unequal distributions of the income in the society. This is somehow related to the allostatic load hypothesis that we studied in the previous. Because we believe a more equal or more fair society actually create less stressful environments for the citizens in the country, so that people can live a little bit healthier in general. So this has a very important policy implication, because if this is really true, well then obviously policymakers should always aim at reducing the inequality within the communities or maybe in the countries. So health status of a society might actually decline even if the average income rises, if the income becomes more concentrated to a certain group of people. Another hypothesis also illustrates the health disparities between different social economic groups. It's by the access to care hypothesis. So in this hypothesis, we actually look into the higher incomes population actually has more resources to devote on health-related spending, such as they can buy a more generous health insurance comparing to the lower income levels populations, or maybe they have basically just more leverage on healthcare. So people with lower income tend to have less generous insurance and face a higher price of care. So that's why the access to care for a lower income population usually is much lower comparing to the higher income populations. So there are some studies also suggesting a low self-reported access to care is a strong predictor of the higher rate of hospitalizations for chronic conditions. So these hospitalizations are actually largely preventable and are considered to be the indicator of poor overall health and inadequate of the outpatient care. Take an example of people who are insured and uninsured. So people with insurance, obviously, they will have a more higher level of access to the healthcare, so that they will be able to get those services to check up, and also whenever they get into problems, they will have the ability to go to a doctor visit. Versus the lower income individual might not have the time, or maybe even not have the resources to seek for this care, or basically it's just too costly for them not to work. But this health disparity actually persists in the country with universal health insurance, which we discussed last time. In the case of the Canadian youth study, even though in Canada most people actually have this healthcare costs paid by the government, we still observe a persistence of health disparities in the country of Canada. In the case of British servants study that we previously talked about, also with the same access to health insurance, also healthcare health disparities also persist. So even if we look across the country, the limited accessing, or maybe unequal opportunity for accessing the care does not totally explain the health disparities in the country. So far we have illustrated how different socioeconomic status might play a role in effects to people have different health outcome in the life. So this health disparities, it's a causality from socioeconomic status to health. But sometimes we might actually find evidence to suggest that the causality goes to reverse. What does it mean? That means in some cases, it might not necessarily to be true that we are in certain socioeconomic status that causing us a better health or worse health. But it could be the case where we are starting with some level of health and end up with in a different level of socioeconomic status. So in this productive time hypothesis, it actually illustrates the causality in the reverse way. So in this case, we are basically trying to explain sometimes bad health actually leading to a lower productive time in life, so that we have less time and less resources to produce income in life. So we end up in a different socioeconomic status. Well, there are several examples illustrated in the book how health stocks in the early in life play a fundamental role in determining education level, properties, and other economic outcomes. But one particular example actually illustrates the effects of early health stocks might actually affect the future socioeconomic status. So in this trend study here, in 2008 and 2007, done by two different researchers, the study actually illustrates the baby that was born sharing a common background and growing up in a similar environment. It isolates the effect of birth weight and other measures of the newborn health. In both studies, it actually found a lower mortality rates for healthier babies, along with the higher education attainment and also higher earning in the adulthoods. They also find that the lower birth weight children actually suffer higher mortality rates relative to the twins or siblings. And this is a causal evidence in favor of the theory phenotypes hypothesis, because we actually explain how early life health status might actually affect the people's lives in the later future. So in this productive time hypothesis, it's more relevant to people with poor health and illustrating how the diminishing marginal return to health in terms of the productive time might actually play a important role to determine whether the person will end up to different socioeconomic groups in the future. So in this diagram here, we actually illustrate health as a productions, right? So the higher level of health we achieve, the more productive time we can actually gain. So such as in point A, with a lower level of health, we will be spending a lot of time sick, so that we don't have much of a productive time in life. But at point B, with a better health in life, well, the productive time will gain a lot, so that we have more time to work, more time to enjoy leisures, more time to spend on health activities. The policy implications in this productive time hypothesis suggest a smaller investments in health that improve in poor country actually might yield a larger economic return. So by that means, if we look at the developing countries in the world, if there is a way that we can actually help improving the health of the general population in the early age, obviously those people will turn into a more productive individuals that driving the developments of the country. So the last hypothesis here we are going to discuss actually trying to explain how health may not directly related to the socioeconomic status of the individuals. In fact, sometimes there might be the third factors out there that putting people into different socioeconomic status and end up to have a different outcomes in health. So this third factor here is basically time preference. So in this hypothesis, we actually predict people who do not discount the future very heavily. They will be well educated and healthy. So basically, we are describing people who are more patient to wait for the returns in the future, so they don't discount the future returns too much. They are the people who will more likely to invest time on education, on health activities, or maybe on different types of investments in their future. On the other hand, people who do not discount who do discount the future heavily will be poorly educated, unhealthy, and happier for it. So people who actually don't have the patience or impatience in life, obviously they care more about the current outcome comparing to the future. So they will be usually don't really want to invest a lot into the future. So people who uh, uh, attending high school and they only care about the current income, they will basically just give up the opportunity to go to college to earn even higher level of income in the future, but earn the current income to start working for full-time jobs. So this time preference actually driving a different behavior for people, whether they would like to go to school to earn a higher education attainment, or to put more time invest on health related activities, or maybe at the end of the day driving them into a different social economic status in the future. So there are basically several case that has illustrates the results, and one of the case it's studied by the Stanford Heart Disease Prevention Program, done by Farrell and Forge in 1982. They tested the Forge hypothesis and find out that the future education disparity actually predicts the current disparity in smoking rates. People who at the age of even just 17 who decided to go to college actually has a much lower rate of smoking. So in this case, obviously, it's not because people attend colleges that causing them to smoke less, but whether we actually assume here in this hypothesis, it's people they valued the futures of returns more, so they basically believe that investing on educations will give them higher values of wealth in the future, and also investing more on health and quitting smoking now will actually give them a better return in health in the future, so that they would choose to do or take certain actions in life. So in general, so come to the end of this chapters. There are several hypotheses that we have discussed, and we also take a look at some of the evidence. There are some very important takeaways in this chapter. So number one, the better educated people generally has a better health even with the same resources. So it's not only just the socioeconomic status here, but the better educated people actually move to higher ranking of socioeconomic status, so that it leads to better health outcome, but not only just by income. It could be just by the fact that people are highly educated, they can actually use the resources, or maybe to make use of the informations better. Health event early in life actually affect health into adulthood. So this is what we have discovered in the 50 phenotypes hypothesis, where the early life health outcome actually affects health in the adulthood for some populations. And also in the allostatic load hypothesis, we learned that the stress actually play a very, very important role in creating the health disparities. And what's important to learn for some policymaker out there, equalizing access actually, or equalizing access to care, healthcare or medical care, does not eliminate health disparities. The disparities was actually generated in many different forms and many different ways. Just by giving equal access of care to the populations might not eliminate or maybe provide an opportunity for everyone to be equally healthy. And at last, there is a two-way relationship between health and socioeconomic status. Not only always we see a better socioeconomic status populations will go leads to a better health, but sometimes it could be the reverse, where the better health population actually at the end of the day make use of these resources that they have to build a better future, to actually get to a higher level of socioeconomic status. So those are the topics that we have covered in this chapter. There's a lot that we went through. Hopefully you can relate this hypothesis with the Grossman model we pick up in chapter 3. And in next chapter, we are starting going through the supply of the healthcare services. So this is basically the last chapter when we talk about the demand side of the healthcare industry. But starting the next chapter, we are going to move on to something that is more related to the producer side of the markets.